Welcome once again to our Wednesday evening mentor session, the FRCS mentor session. It's a pleasure to have you all again with us. Today we're very lucky to have one of our freshest mentors, just recently passed the exam, Abdullah Gabr. First of all, congratulations, Abdullah, well done. I know you worked really hard, well deserved. But what we're lucky in this scenario is that he is going to be telling us about how to pass the FRCS exam. And there has been some changes since I last sat, not least because of COVID. So I'm really looking forward to hearing some of these tips and advices on how to cope with this new format in the exam as well. Please don't be afraid to ask questions. Put it in the chat box. Hussam Albani, one of our veteran mentors, will sift through them and provide ask the questions at the end. And as always, we do have a hot seat Viva session after the recorded part of this section. So please do volunteer. Send me a private message in the message group and I will take notes of who wants to be asked. We appreciate that the exam is far away, but for you guys, I think the more active you are now, the better you will do later. Okay. So looking forward to this at the hot seat session with you all. Without further ado, Abdullah Gabr, it's a real pleasure. Please go ahead.
Thank you, Sean. It's a pleasure to be with you all. Thank you for giving me your time. I am Abdullah Gabr. I just passed recently my exam, and I would like to share my experience with you and give you the tips and tricks of this exam. I just first want to say that this is my own experience. It is not essentially going to be useful for all of you, but I think many points will be helpful for most of you. This talk is mainly about the part 2. However, I just quick talk about part 1. I just want to say part 1 is quite straightforward. If you study, if you have the knowledge, you're going to pass. Easy. Okay. You have, with regard to your study, choose whatever the source. Personally, I choose Miller. It was quite straightforward. I studied Drama Chandran for the basic science, and I just studied the MCQ of the Orthopaedic, the free version. I didn't pay for any money for the upgraded version. Some people study from Orthopaedic. That's fine, but the main thing is that you have to study the book from the cover to the cover. Be careful that there are some rare topics that you don't see frequently in your practice that comes frequently in the exam. For example, there was quite a lot of questions from bone dysplasias, about statistics, about orthotics, prosthetics. All of these things you have to study. Don't ignore them. Don't say that these things are not common, so they're not going to come. They love these points. So study the cover from the cover. I studied Miller twice or 2.5 times and repeated the MCQ orthobullets twice, and my score was very good in the MCQ. I passed very easily. Another trick is that I found it very useful to take a lot of time before part 1 and less time before part 2. So what happened? Actually, I was quite lucky that my part 1 was cancelled. I just gave it 6 months before part 1, but it was cancelled. So I said, okay, I'm going to study part 1 and part 2 before part 1. All right, because there was a lot of time. But I found this technique was very useful because, first of all, it helped me in part 1 because a lot of topics came in the MCQ came from the part 2 from Banaskovich book. And the most important is that I was very fresh in part 2 with the knowledge. So I finished part 1 and then applied the next exam for part 2. I found it very useful. So my advice is that take 1 year before part 1, study as much as you can part 1, and if you can study part 2 as well, and just take few months before part 2. You will be fresh on part 2, in part 2 with regard to the knowledge. And you have to study, I mean, you have to prepare yourself. This year will be a hard year. You have to study quite a lot. So I would say that you have to study 20 to 30 hours every week. This means that you have to study every day. On weekdays, you have to study 2 to 3 hours after you work. And in weekends, every day you have to study about 5 to 6 hours. This is for 1 year. So prepare in advance, sit with yourself, free yourself, speak to your family, that this year you will be very busy, okay? This about part 1. With regard to the part 2, this is the tricky part, okay? Part 2, I know a lot of people, a lot of my senior colleagues, they are very knowledgeable, they are very senior, they studied well, but they didn't pass. And the reason is they didn't fill the criteria to pass. And the criteria here is not about knowledge. You have to show that you are systematic, you have a technique, and you are safe. So actually, I look at it the other way around. So you have to show first that you are safe. If you don't look safe, you're not going to score 6, whatever the knowledge you have. Okay, so I actually look it around the other way around. You have to start safe. You have to show the technique. This is the easiest part, but this is the thing that's gonna bring you to lay the basis of your mark. Okay, and then you have to show that you have a depth of knowledge. And we'll go through each one of these points. So I will start by safety. So safety is the easy thing. So I will give you an example. One of my colleagues in his exam, he was given a picture of a dislocated total shoulder replacement. So he started to panic because he didn't expect this question, okay? Because he just expected like a dislocated shoulder, but it was dislocated total shoulder and it was loose and things. So he started to panic and started to rush to the revision, the manipulation, the blah, blah, blah. And he forgot about the neurovascular assessment. He didn't pass this table. He didn't pass this question because he didn't look safe, okay? So safety is the easiest thing to score, but it is the easiest thing to fail as well if you didn't look safe in the exam. So safety, things are simple things. For example, if you have a polytrauma, you have to mention that you have to do the ATLS. If you have, for example, a femoral shaft fracture in pediatric group, you have to mention the NAI. If you have a spinal trauma, you have to mention that you're gonna discuss with the spinal surgeon and you're gonna get an MRI. If you have an emergency, for example, compartment syndrome, tendon sheath infection, dislocations, or septic arthritis, mention to the examiner that this is a surgical emergency. Show you are safe. Okay, this is safety. It's easy to, it is few things easy, but I tell you that under the stress, many of us forget these things. The other point is that you have to be systematic. Guys, remember that you have 5 minutes to mention all the topic, to go through all the topic. And if you don't have a frame, or if you don't have a system, you're gonna lose your points. So I found the 5 Ds of Rishi very useful to go through. So the first thing is describe the X-ray or the MRI or the picture you get. The second thing, after description, you say the diagnosis. Then the discussion. Discussion here means the history, the examination, the investigation. Then decide which is the treatment. And at the end, if you come to this point, which is either debate or diagram or evidence, I mean evidence instead of detective, then you are scoring high, you are scoring 7 or 8. And we'll go through each point of these. So describe. If you're given this picture, you don't say that this is a made lung deformity. Okay? No, start to describe the findings on the X-ray. Say that there is an increased radial inclination, there is incongruency of the DRUJ. My top differential diagnosis is made lung deformity. This is the way you have to speak in the exam. The examiner will feel that you know. Okay. Other thing in description, elaborates more on the X-ray. So here it's a picture of Kienbock disease, but you say first that this is there's sclerosis of the lunate bone. Of course, you have to start with this is a PE radiograph of the wrist, or this is an MRI T1 sequence or whatever, and then describe that there's sclerosis of the lunate bone. Don't stop here. Elaborate more. Say there's a ulnar minus deformity. Mention if there's no metacarpal arthritis, there is no band wrist arthritis, and this is a Kienbock. Then you give the diagnosis. And when you give the diagnosis, try to be more specific, if you can. For example, this is a Kienbock stage 3 or stage 3A. Okay, try to elaborate more on your description. Okay. Then the second point is diagnosis. As I told you, try to be specific in your diagnosis. If you have classification, mention the classification, especially in trauma. And I found in the exam that they still asking about classification. Then the discussion. The discussion is the history, examination, investigation, and investigation can be laboratory or radiological. Now in the clinical, and the clinicals you have, this is the flesh of the clinical. You have to spend a lot of time in clinical examination, in discussion part. But in Viva, you need to speak less in the discussion part. Just mention the bullet points. Don't elaborate much. For example, in this X-ray, if this is a calcaneonavicular coalition, in clinical examination, you just say that I'm gonna expect that there's a fixed flat foot deformity. Stop. You don't have to say that the hind foot is gonna be in valgus, they're gonna be callosities. I'm gonna ask the patient to walk. You don't have to mention that. You have only 5 minutes. You have to go quick through this. Okay. And in history, try to compartmentalize, for example, history of present complaint. In other topic, history of present complaint, risk factor histories. Try to give it signpost and go through the history this way. And the last thing in discussion is investigation. Make sure that you ordered all the investigations before you go to theater, which is the decision. So in this case, many people, because of the stress or the heat of the exam, they forget about getting the MRI or forgetting actually the easiest thing, the simple thing, other views of the X-ray. Make sure that you got all investigations before before going to theater, okay? Then decision. Decision, there are a few points. One, don't forget about the non-operative management. For example, one of my colleagues, he had a Dupuytren contracture. So he straight away went for the operative management, limited fascectomy, blah, blah, blah. After he finished, the examiner looked at him and he said, well, the patient is asymptomatic. He forgot about the non-operative management, okay? This is one point. The next point, especially in trauma, try to give the initial management. Don't forget the initial management and definitive management. So initial management in A&E can be like pain control, application of the casts, admission, monitor for compartment syndrome. This is all before the definitive treatment. This is gonna count. This is gonna show the examiner that you are systematic. Another thing is that don't enumerate options, okay? Speak like a consultant. If you are in the trauma meeting or in the morning meeting, the consultant will look on the x-ray and he will say, I'm gonna do that. He's not gonna recite the book. He's not gonna say the options are this, or this, except in very controversial situations that you can say the options, okay? Then you have to elaborate on your definitive management. So, for example, my bimalleolar ankle fracture. Don't say I'm gonna do ORIF and you stop. No, say I'm gonna do ORIF, the lateral side. I'm gonna do a lag screw, neutralization plate. Then I'm gonna reduce the medial side. I'm gonna do I'm gonna do two partially threaded cannulated screws. Then I'm gonna check the syndesmosis. So elaborate more. Don't just say the ORIF treatment. The last part in this scheme is this is the extra mark here, is diagram or evidence or debate. So diagram, to practice the diagrams before the exam. The diagram should take 30 seconds to draw. And you have to practice talking while drawing. And when you draw something, try on larger scale. Don't do a small drawing. This when you draw, so a paper for every drawing. This will show that you are confident. Detective means here is the evidence for the. I mean, I found in the whole of my exam, I was asked once about the evidence. I was able to bring one evidence, which was the SWIFT trial, of all of the evidence I know. So the things that if you know a lot of evidence, that's fine. But sometimes people concentrate more on the evidence more than the knowledge itself. So don't do that. And for the evidence, there are a few things that you have to know by heart, which is the BOST guidelines. You have to study them in out. There's no excuse about it. The nice guidelines, you have to study few of them. If you can study more, that's fine. But nice guidelines, you have to study for the one for the diabetic foot, the one for the osteoporosis, the one for osteoarthritis, the one for metastatic spinal cord compression. Also, among the evidence is the NGR results. Go through them. This is for the hip, for the knee, for the shoulder, the elbow, and the ankle. And for the trials, you have to know a few of them, which are quite common to come in the exam, which is the Profer, the Draft, the Swift, the UK Hale, Baumgartner-Weber for DHS, Ledwell for SUFI, and Cooker for septic arthritis. I think if these are more or less the papers that you're gonna need for your exam. If you know more, that's fine, but just make sure that you know these papers well. Now we have talked about the safety. We have talked about the technique. And just with regard to your knowledge, if the examiner want to make difficult scenarios, they can put two topics together, blend them, and then this, you're gonna see how you're gonna answer, whether this confuses you or not. For example, femoral shaft fracture in non-walking child. You have to talk about management of NAI, and don't forget to mention the management of the femoral shaft fracture. So it's two topics together can confuse you a bit. So practice these things. Another example, atypical subtrochanteric fracture on Paget disease. So this loads of topic. You have to be familiar with the Paget disease. You have to be familiar with subtrochanteric fracture, reduction, non-healing. You have to be familiar with the bisphosphonates this way. Another example is scoliosis secondary to neurofibromatosis, and actually this topic came twice to me in my exam. So you have to be familiar with the scoliosis, how to examine the scoliosis, and at the same time you have to be familiar about the neurofibromatosis. Another thing, scoliosis with Marfan syndrome. You have to be familiar about both topics and the criteria, the characteristics of both. Another example is posterior hip dislocation plus sciatic nerve palsy, and actually this question came to me, and actually the examiner tricked me, and I forgot completely about the sciatic nerve palsy. So the question came to me that posterior hip dislocations, so after ETLS management and all the initial management, I took him to theater to show that I am safe, and tried to relocate it. It didn't relocate. So he asked me, what are you gonna do? I said, I'm not gonna open it because I'm not a pelvic surgeon. Why are you not gonna open it? Because I don't want to destroy the approach for the pelvic surgeon. Okay, you are the pelvic surgeon. So I said, okay, I'm gonna do relocation, open relocation through the posterior approach of the hip, and that described the posterior approach. And he said, that's it. I said, that's it. So he said, okay, what about the sciatic nerve palsy? I said, okay, sorry, I'm gonna explore it. So that's fine. I mean, sometimes under stress, you can forget a few things, but the examiner can prompt you, no problems. But one of the tricks, actually, one friend told me, just try to write the question while when the examiner give you the information, write them so you don't forget them in the heat of the exam. With regard to the clinicals, you know, there's no real patients. It's all like pictures, and I found the clinicals is just a viva, concentrating more on the clinical examination. Just be systematic again in the clinical. So the best way is to have the lock, feel, move special test. This is the easiest way to have a system. For example, one of my colleagues, he was given a rotator cuff shoulder examination for rotator cuff tear. And he started systematic, okay? And then when he turned around the patient, he found that there's a scoliotic deformity, and which was quite strange. So he started to mumble and started to lose the track, and he didn't do well in this station. And the things that don't lose your track. So it's easy if you concentrate on examination of the shoulder. And when you say, for example, this scoliotic deformity, just mention it, acknowledge it. Just say that there's a thoracolumbar scoliotic deformity, there's the apex to the right, and come back again to the shoulder, the lock, feel, move. So don't be distracted away from your system. So in the exam, I'm not going to say that you have to sleep well, you have to dress well, you have to manage your nerves. This is very important. But I have to say that, guys, the exam is more difficult than you expect. I'm sorry to say that. Whatever the courses, the Viva courses you attended, it's more difficult than it. Whatever the sources you studied from, there will be like about 4 or 5 questions you have never ever heard about it. And I'm not saying that to upset you. I'm saying that to let you know that that's fine. This is the normal. When you go into the exam, when you are in the exam, don't get stressed. Control yourself. This is very important. If you don't answer a question or 2 or 3, just leave them and concentrate on focus on the remainings. It's very easy to get the marks and compensate for the 5s. That's easy. So I'm just saying that it is more difficult, so you don't get shocked in the exam. Other point in the exam is that you have to show your soft skills. What I mean is that the management skill, the communication skills. For example, a question came to one of my colleagues. He had Guillain Canal syndrome. So he mentioned that he's gonna get an MRI to look for a space occupying lesion. So the examiner said, okay, that there is a space occupying lesion. What are you gonna do? The patient is symptomatic. I'm gonna do a release of the Guillain Canal. So you are in theater now, and you open the Guillain Canal, and you found that there is a lesion, aggressive lesion coming from the nerve itself. What are you gonna do? So the answer here is that actually no one knows. I mean, my colleague didn't know what to do, but the answer is show your soft skills, which is first of all say, I'm sorry, I should have elaborated more on the MRI, but now I am in theater. I'm not quite sure, but I will get help from one of my senior colleagues, or I'm gonna descrub and call the tumor center, and then say the options. I am not quite sure. The options are either to excise the lesion, but I don't know whether it is malignant or benign, or the other option, the safer option, is just to take a biopsy and close everything and come back to this case later. So if you don't know, that's fine, no problems, especially in the advanced cases, but show some thinking, so high order thinking. And if you say something in the exam and the examiner told you, are you sure? It's more likely that you said something wrong. So step back, think about what you said, and start again. That's fine, no problems. If you say something wrong, say, I'm sorry, I retract what I've said, I'm gonna start it again, no problems. Because sometimes if you say something wrong, the examiner can take you completely out of your pathway and take you somewhere you don't know. For example, in my exam, I said there was a degenerative scoliotic lumbar deformity, and I said, what investigation? I said, MRI. He said, anything before MRI? I said, full spine X-ray. So I said, I dig a hole for myself. So he said, why you, I mean, he tried to prompt me to, I think the answer was to get a flexion extension X-ray to look for stability. But I said full spine MRI. And then he started to prompt me, why full spine MRI? I said, to look for, I didn't find anything to say, but I said, I'm gonna look for the sagittal balance. So I dig another hole for myself. And what is sagittal balance? Then I start to mumble, okay, what is positive sagittal balance? What is the importance of positive sagittal balance? What is the importance of negative sagittal balance? And I didn't do well in this question, because I think I took myself away. I should have said, I'm not quite sure what is for MRI. And instead of saying something nonsense, I shouldn't have said it. Other point, if you don't know something, if you are not quite sure about something, say, I am not sure, but I think it may be this way. So don't be overconfident. If you say something false and you don't have insight, this is some problem with safety. And as I told you before, try to compartmentalize your answer. So start with the preoperative, for example, in management of Paget's disease. Say management will be preoperative, operative, postoperative. Or for example, examination, or for the case of septic arthritis, it will be general and local examination. Or other example will be patient factor, surgical factor, implant factor in some of basic science scenarios. So try to compartmentalize your answer. This will give you more marks. Before the exam, guys, prepare yourself. You have to study. You have to work hard for the exam. You have to study a lot of time. And you have to practice. This is very important. You have to find a study partner with you, 1 or 2 at least. So 1 at least, 2 or 3 maximum. And I was surprised that some of my colleagues, they called me 1 month before the exam, that I'm talking about part 2, that they didn't have a partner with them. And I think, in my opinion, I think there's no way around to have a study partner to practice with. In your hospital, try to practice on the cases you see in the clinic on the on-call. I was surprised that I tried to do carpal tunnel examination 1 month before the exam and found that there were a lot of defects in my clinical examination. Try to practice with a senior colleague or with your consultant. And without saying, I found that this FRCS mentor group was very useful for me during my preparation. Thank you for them. Other point is the basic science. Basic science is a gift. It's really a gift. You can score very high in the basic science and compensate for other stations. And basic science, because we are not familiar with it, we find that it is difficult in the start. But once you study it once and twice, it will be the easiest part in the exam. It's the easiest way to score. Plus basic science is the anatomy. You can't be a safe surgeon without being good in anatomy. You have to study the anatomy very well. And this is for part 2 and for part 1 and part 2. And very important is that don't panic, control yourself. I mean, the exam is difficult. You gonna lose some question. You're not gonna answer all questions, but that's fine. Forget about them. Try to think about the next stations. And last thing is failure. I hope all of you pass from the first time, but if you fail, I mean, I know it is a terrible experience. You will start to hate yourself. You're gonna feel that the life gonna stop, your work, your career gonna stop, your family life is wasted. You're gonna feel all of that. But I have to say that this is normal. This is physiological, okay? I would say that don't open the book for 2 weeks. Try to be good with yourself. Don't be tough with yourself. Go hang out with friends. Do something to get out of the stress, and return back to your study. But think about why you failed. Where was the problem? Is it your knowledge? Is it your technique? Is it something about luck? Speak to your senior colleagues, speak to the consultants. Usually you're gonna find that, that I should have done this instead of this. I should have done that instead of that. And in my opinion, if your knowledge is good, it's easy to work on your technique in 1 or 2 months. So if you have the opportunity, don't wait for another year for the exam. Just book the next exam and work on your technique if you have the knowledge. Of course, if you have defect in the knowledge, you have to spend more time. But the easiest thing to bring in the exam is safety. Safety is easy. Then the technique, you can practice the technique in 1 or 2 months and you will be absolutely fine. The knowledge will take most of the time. And that's why I'm saying try to book set the part 2 straight away after part 1. So you are more fresh with the knowledge. I hope all of you pass, and good luck for all of you. And if any questions, I'm happy for that.
Thank you very much, Abdullah. Once again, I've noticed a common theme through the 3 years we've been doing this, 3.5 years now. Every person that's given a talk on how to pass the exam have said the same things. Basic science, absolutely key. Technique and safety. Would you agree that literally those 3 are the priorities in terms of how to pass the part 2?
This is in many times is the deficient part, and a lot of. So, for example, I know one of my colleagues. He's a senior hip surgeon. He does loads of hip and knee replacement, and you will be surprised that he didn't pass the arthroplasty question. Not because of his knowledge, but he was not able to get the technique. He was not able to convey his knowledge in 5 minutes.
Yeah, absolutely. So, Hussam, first of all, I'd like to welcome Abdullah Hanoun and Kashif Mamoon, both veteran mentors who just joined us a little bit late into the program. They'll have live questions as well. So, Hussam, do we have any questions?
Yes, we have few. So the first question is from Mr. Mutwalli. He said how to make a balance between directly jumping to the most obvious thing in the X-ray to save time, but on the other hand, being systematic, starting by describing the view and modality of the imaging.
It's a bit tricky, but I mean the buzzword here is to practice and practice and practice. Your description shouldn't be more than 30 seconds. You don't have to mention everything you don't have to mention everything in the X-ray, but at least the 80% of the findings. To be honest, I found some examiners that wanted me to describe that this is a PE X-ray of the knee showing this and this, and others were fine. They didn't bother about the very basic things. So it's sometimes tricky. For example, a valgus knee with osteoarthritis. So you don't have to mention that this is, say this is a weight-bearing X-ray showing advanced arthritis with valgus deformity. There's bone loss, there's ligamentous laxity, there's subluxation. All done. This is less than 20 seconds. But if you start saying that there is narrowing of the joint space, there is osteophytes, there is subchondral sclerosis, there is a cyst. These are this is for SHO level. So you just need to speak like a consultant when you are in the trauma meeting or in the morning meeting. The consultant will comment on these things.
Yeah. So if I would expand a little bit on this, I've been told when I was taking the exam to strike this balance, just to look at the X-ray and then this is an AP radiograph or PA radiograph of the wrist, AP and lateral. The most striking feature over here that I can see is sclerosis at the lunate area, which put the Cohen's disease on the top of my differential diagnosis. Having said that, it could be blah, 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 whatever you want to say after that. But you made the examiner, some of them, once they hear the Cohen's book, they will stop you there and then they will move on. So this buzzword of the most striking feature, is, or I'm concerned about this. So, and then move on. Okay, sorry about that. Next question is from Mr. Mohammed Mahmoud. How to reach the balance between knowing the topic well and be concise in 5 minutes answer?
So, I mean, in many occasions, the examiner will help you. So, for example, if the examiner needs the management part, he will push you toward the management. And for example, sometimes actually he can tell you that the history and clinical examination findings straight away. So I mean, the 5 minutes is made to be suitable to give all the answer. Okay. Sometimes, which I found in this exam, that some question the examiner didn't want the management. He wanted something else. For example, he showed me a loose Charnley hip, and he said to me, "This is infected." So initially, I said, "Okay, that's a good question. I'm going to go about the revision, the evidence for revision, the two-stage revision, all of that." But he completely took me from this path and started to talk about what is the risk factors for infection, general and local. What is diabetes? How does it affect? How it can cause infection? What's the HbA1c? What's rheumatoid arthritis? And this was in the adult path table. So I found that 5 minutes is usually enough, and the examiner will push you towards the part. It's usually the management, but in general, he will push you towards the part he wants to hear from you.
Good.
Could I also intervene with a small comment on this? So what I find most commonly as to why a person finds they've run out of time is not because they have not covered the topic. It's they've covered the topic in a very poor format. So the classical scenario is, for example, let's just put up something, a forearm fracture, mid-shaft, on a 8-year-old boy, okay? What tends to happen is the person who's not prepared for the exam and has a technique issue will ask the examiner questions. The questions they'll ask is, what time did it happen? Is he fasting? Is he not fasting? Is there I will assess for neurovascular. Is there neurovascular injury? Oh yeah, is it open? And the examiner will tell you the patient's in pain, telling you move on to management. What you then go is, oh, I will assess for compartment syndrome. Is there compartment syndrome? Okay. And now you've wasted a minute to a minute and a half talking nonsense, when in 10 seconds you can cover this. This is a both bone forearm off-ended radius and ulnar mid-shaft fracture in an 8-year-old boy. Demonstrate it on the APM lateral X-ray. I would, of course, presuming this is a closed injury, neurovascularly intact, and no evidence of NAI and or compartment syndrome, I will proceed with analgesia, splintage, and plan to have this patient done on the next morning operating list. If the examiner wants to talk to you about compartment syndrome or NAI, they'll stop you and say, we didn't say there's no NAI. Okay, or we didn't say there's no compartment syndrome, or we didn't say it's an open or closed injury. So that means go back to that topic. But in 10 seconds, I have now moved on to management. Okay?
Absolutely, yeah.
It's the same for adults, assuming there are no medical comorbidities that would need optimization and or management before taken to theatre, and the patient's not on any blood thinners. You can add that extra line and you're there. Okay, does that all make sense, guys? It's a technique issue most of the time if you're finding you're not having time.
Can I please add one extra point again, which will help? That helps actually both if you know too much and if you don't know enough. It works both ways, which is what you've mentioned, Abdullah, which is to have a skeleton. So if you want to talk about a big topic, and you know that you cannot cover the whole topic, that works mainly for basic science, then have a sieve in your mind, pre-op, intra-op, post-op. Just you mention that. Now, even if you did not manage to cover everything, and you cover a bit of each one, they have to give you the mark for it. And they will lead you down the way that they want the question to go for. For example, if they want to focus on the pre-op or the inflammatory causes or the whatever, then they will go back and ask you about it. But by mentioning the main names, number one, you've gained the marks for everything, you put your minds at ease, and you got the, you know, you are on the way to going deeper later. And again, it works if you don't know much, then at least you gave yourself a bit of time to think. Yes.
Absolutely.
Yeah, it personally happened with me also. It's like in my exam, it was a very complex polytrauma, and I thought he would ask me about the blood transfusion and all this. Anyway, it turns to be like he was fracture dislocation of the hip, and I said, yeah, assuming that the patient has been assessed and managed according to the ATLS protocol, and this is a closed injury and there is no other injuries. He said he has other injuries, but I will tell you later. And then we carried on. And then the thing that you don't forget that he told you there is another injury. So you will go and ask about it again. And in my case was he has fracture of the tibia and fibula of the leg. So, and that was about what to do first and all this. And it's about of damage control versus just treating everything. And the thing was asking after fixing the hip, we put X-fix, after fixing the hip, is a patient still stable or not? So he just says stable, and it was easy. Just I will put I am nail if the patient is still stable. So it is about this assuming, and he will stop you if he wants. What materials did you use for part 2?
So part 2, you there's no one source enough for the part 2. So I mainly used the Panaskovich. I supplemented then with second thing Miller, and third thing I used the concise book. But this was the order of the. Of course, I had some notes from one of my friends, some scribbling here and there, but the answer is there's no book can give you the full knowledge for part 2. You have to use multiple sources, but make one source as the main source.
The source that you use, and the problem is you might not find the right source for you. So you may end up going through 2 or 3 different sources. So Orthobullets, postgraduate, concise orthopedic, whatever. I don't particularly care. What is important is you find what is suitable for yourself. For me, I couldn't read postgraduate orthopedics because I just couldn't read it, and I found Miller really difficult to read as well. But that's me. Okay, so I prefer to use Chandran for my basic science and Orthobullets and multiple internet websites on the basic science stuff, because I always found it wasn't enough to understand the topic. So other people will use, and of course I use my reference books. Well, some of them are outdated, by the way. The other people will read Miller book to thing and will be perfect. So if you're asking, my advice is actually go to the library, go pull out those books and see which format suits you. It's very easy to go into Orthobullets and look at the format there and decide if that suits you. I'm not going to make any recommendations. I don't think any mentor should make recommendations for a person unless they know that person really well. Mentors, do you all agree or disagree?
Yeah.
Please disagree if I'm wrong.
Yes.
No, you're absolutely right.
Thank you.
Can I explain something, my philosophy, which is very close to your philosophy, Shwad? The reason for the book, to be honest, is to give you a skeleton. I like this word, to give you a skeleton whereby you know which topics to cover, so that you don't miss one topic from the exam. As long as there is a book that tells you these are the things you need to cover, that is enough. And to be honest, the best way is not to read the book. You use the book as basis for discussion with your co-colleagues who are preparing with you. So you are not reading. And that's why when people ask me this question, I go on a lecture, because people have different concepts. They want to read a book, memorize it, and go for the exam. That is completely the wrong approach. The approach is, you want something to tell you, today we will be group studying basic arthroplasty of the knee. And you go and read whatever you want to do, and then come and discuss it with your colleagues, cover all aspects of it, imagine what questions that can come in the exam, and prepare for them. This is how you read. It's not the book. And that's why every time someone asks me that, I give them a lecture.
Can I also add that you need to write some notes? So every page you read, for example, I started from the Paniskovich, the postgraduate. Postgraduate is good, but it's very extensive, and sometimes there's a lot of repetition. It's a good book, but has its own problem. It's very extensive. It's 900 pages, and yet is not complete. So I used to, every page you go through, every page you have to summarize it in about 5 lines. So when you come back, when you revise, you can't revise the whole book. Just you revise you have knowledge in your mind, but exactly as Abdullah said, just to revise the skeleton. What you're gonna say?
I will give my input. Sorry, Abdullah, I used to write everything, and I never, ever went back and read it. Every time, having gone through this exam, and I passed the 4th time, so every time I was writing my notes, and I never went and read it again. Anyway, I took it as, I still do it, because it is like saying it again.
Yeah.
My way, as Shwan said, and everyone said, we all different. So I don't like reading, actually. I like listening more. And we are lucky now, with the help of FRCS mentors and many other activities around now after the COVID, that we have a lot of these webinars, recorded webinars, which summarize and concise the subject from FRCS point of view. So my way, I would say, I will read once. I read Miller once, so I feel that I read everything. I read Paniskovich, that's before the first part. I read Paniskovich once, and after that I found, for part 1, is that MCQ answers is what I'm now studying. So I try to practice MCQ, whatever, if I'm right or wrong, I will read the answer. And from there, it will stick here. For the second part, is the small books, because whatever I've read in Paniskovich is too much, and it is difficult to bring it in the exam in 5 minutes, if we're talking about 5 minutes.
Absolutely. Yeah.
But these books, question books, is actually concise the answers. So as Abdullah said, Abdullah Hanoun, is just making a scaffold and a system structure in your mind, what is required, what you should answer. And I have been told, never ever try to remember more than 3 in everything. That's called the power of 3. So any causes, any differential diagnosis, basic science, anything, remember 3. And that's it, the most important.
So as you can see, you've heard 4 different techniques so far. I'm sure Kashif has a different opinion as well. So we're going to stop there. I really do appreciate everyone has a different technique of studying, and everyone has a different way of studying. You have to do what is right for you. And asking which book and so on, don't take our word for it. Go to the library, open the books you want, and study the technique that suits you. Okay, that's all that matters. Yes, do find a book that suits you or a source of knowledge that suits you as your go-to knowledge, but it doesn't have to be reading book cover to cover, as being demonstrated by a couple of the mentors here. Okay, does that make sense? By the way, we are not advocating skeleton knowledge. We are advocating skeleton answers. There's a difference between the two. Okay, please do appreciate that. Okay, next question, Hassan.
Okay, so these questions, again, I think the answer will be the same, but let's put it on. How many mock exams before the actual exam? And the other question related, any courses recommended or a must? And the third question, actually, with regards to practice question for part 1, is OrthoBullet sufficient? I feel these questions are related to that one, but I will let Abdullah.
Yeah, so I'll start with the last question. In my opinion, I found OrthoBullet, the free version, is enough. I did it twice. I didn't pay for anything, and there's about 3,500 questions. And just for completeness, I did about 3 or 4 years of the SICOT, but I didn't like it. Is not written very well, but I just did like 2-3 years because it is slightly similar more to the exam style, but it's not going to give you any knowledge. Is not written very well. This is my opinion. This is the last. Yeah. The other question is the courses. I was a bit unlucky because it was in the COVID time. So all the courses I applied, it was cancelled. But I'll say to you one thing, is that if you want to get the most of the course, you have to be prepared about it. So I studied well, and at the end, I did the course. Don't go to the course and you don't know anything. If you want to get 70 or 80% of the course, you have to be very well prepared in advance. So you have to do 1 Viva course at least. So I did 1 Viva course. I did 1 clinical examination course. I did general knowledge course, 3 courses, I think, 3 or 4 courses. This was, I didn't do much, and I found that this was sufficient. But the idea is that I was prepared well before the course.
How many mock exams before the actual exam?
1.
What do you mean mock exams? I never had access to mock exams.
Like Viva or clinical examination.
You mean like Writington or something like that?
Like the one you do.
Okay, all right, I see. As in the weekend course. Then.
Yeah.
Yeah, the Viva online. All right. Yeah, no, sorry. I thought there was someone offering full mock exam type thing because I haven't seen anything like that. I'm going to go a little bit more different to Abdullah again, just because I want to show you that there is a huge difference. I found OrthoBullets. I paid for the full version of OrthoBullets. I found it amazing for knowledge, and you learned your question when you answered the questions. You learned the knowledge behind the questions really well, but the phrasing of the knowledge made it very difficult for me to do the part 1. When I went to the SICOT as my next one, I found it clicked in my head the way they asked the questions and what the meaning behind the questions, the higher order thinking. Because the OrthoBullets tend to ask the questions in a they give you a pretty much, correct me if I'm wrong unless something has changed, but they still look the same to me. They ask you the question in a 3 or 4 line. They give you the full parameters of everything, and then give you 5 answers, which 2 of which are probably reasonable, but the other 2 are not, and 1 is completely out of a thing. While in the FRCS exam, they will literally give you one line. Sometimes it's even 4 or 5 words. And the answer is not the question, but the meaning behind the question and the higher order thinking behind the question, which is very hard to describe unless you go through the UKITE. As Abdullah said, it's more closer to that format if you go through the UKITE, or if you go for FRCS UK Viva UK Part 1 ones, go through those books. You'll see the way they've asked those questions are very different to the way Orthobullets have asked the questions. The flip side is I have met many of the mentors and many of the guys who've passed who've said all they've done is used Orthobullets. So I'm not telling you, again, this is the same thing. People ask these questions and they think we're giving you Bible answers or Quran answers or Talmud answers or whatever your book is. It's not. It's all about what suits you and what works for you. And if something's not working, explore the other options before it's too late. Okay? And it's better to start much earlier.
I would say, Shwan, is Orthobullets is for more like knowledge, but in form of questions. So if you didn't read the answers, then you will not benefit from Orthobullets that much.
Exactly.
UKITE, it doesn't come with that much of explanation and papers and in the answer, but it is the format that you will go. So if it's me, I'll go Orthobullets first, read the answers even for the correctly answered that I did, and then close to the exam, I will do UKITE. And this is the real measure. If I talk about mock exam, this is my mock exam actually, not the studying.
Can I mention that Orthobullet has something unique to it, which you don't find in any other book, which is after the answer, you would find a good discussion where people did not like the answer that was given. And they were saying, why did you do this? And how come, how about if the question was that? This I found even more useful than the questions above or even the answer. This discussion is the thing that would make you think beyond just the simple question, because these questions will never come like they are in the real exam. So you will never see the same format, but by reading the discussion, it would open your mind.
Yeah. So once again, guys, it's Abdullah is right, Hussam is right, and Abdullah is right. I'm probably very wrong. But you see that there are different viewpoints on all of this. So once again, I cannot iterate this enough. Start early with your studying and start exploring the different methods that work for you. You might already know what works for you. Terrific. Then go look for the books, courses, and MCQs that suit you, or the knowledge where it suits you. But these questions are not easy. And if you're asking me to name courses, I can name 100 courses. But my advice is talk to somebody you know well enough that knows you, that will tell you which one will benefit you. And the courses change every few years. And there are some which were really good 2 years ago, which are not good now. And vice versa, some which have become extremely expensive compared to others. And you get the same amount. So remember, you have a budget as well. So you have to think along those lines as well. We, of course, are biased, and we say our Wednesday sessions are really worthwhile. And if you volunteer for the hot seats, you will benefit maximally from these Wednesday sessions. But that's us being biased. Sam, if there is no more questions.
One more.
Okay. Before we move to the next question, may I mention something, please, guys, for the courses? It depends on where, everyone says that. It depends on what your background and where are your weaknesses. And because you need these courses to cover your weaknesses. For me, there wasn't enough, the mentor group was not well established at the time. So I went for one course at the beginning, before even starting the reading, just to see what is this exam, what does that mean, what do I need to do to prepare for it? And I would recommend for people who don't know where they stand, okay, to do one course right at the beginning, have a course that covers everything, have a flavor of everything, see where your weaknesses are, and then plan for a year ahead of all these courses, okay? So this would help. But for the time being, I feel that our mentor group, because we do it every week and we do every week, you know, the weekend we have these courses, so that would probably complement and make you not need this. But, you know, this is something you have to think of. Sorry, Hassam. Yes.
Shwan Sriram here, if I may say something, if you don't mind.
Welcome. Sorry. How are you doing, Sriram? Thank you for joining us. Another
No, absolutely. I've been here for some time. I mean, I cannot emphasize, and I agree totally with Abdullah. I mean, 2 weeks ago, I taught in the Norwich FRCS course. It is exactly what we're doing it every week. It is a huge sum of money that we pay for all the courses. Just because we're doing it free of charge every week doesn't mean that we're not doing any less jobs. I mean, it is all online now at this particular minute. And it was the Norwich FRCS was, I did the Viva bit for about half a day. Exactly the same thing. And I think if I were to do the exam all over again, I would attend a Wednesday every week. Just practice in Viva, get chatted, see how it goes after 6 months and take it from there. I think we're doing an amazing job, not to flatter ourselves, but I think that's what I would do.
Okay, thank you so much, sir. I appreciate the flattery, but you're not getting any extra marks for that. So any Hassan,
one last question back to the clinical. So this for everyone, I think. During a carpal tunnel procedure, you discovered the swelling from flexor tendon sheath.
Hussam, finish reading the question, and we're not answering this. We're going to end with this. I'll ask this question in the Viva, and we'll see. And Hussam, who asked it? He's going to answer it. Okay.
Okay.
So we'll get him to answer it in the Viva session.
Okay.
This is actually an exam question potentially.
Yeah.
Okay.
Should I? Yeah.
No, don't bother. No, because it's a good.
Yeah, it's a very clinical.
We're not going to answer it. It's a good Viva question, and we'll treat it as a Viva. Abdullah, have you anything else to end? Abdullah Gabr?
No, I think that's it.
Okay, really good talk. As you can see, really stimulating, and also I love your technique of the Ds. I think that is very clever. So I think if there's any take-home message here, that is it's really well done. This will be put on the YouTube channel. As always, you're very welcome to volunteer for the hot seat sessions afterwards, but we're not recording that. So thank you to everyone, including our good showing from the mentors. We will see you again next week. I'll stop the recording here.